Good morning, everyone. I'm Beth Raucher. Welcome to Grand Rounds. I will be sitting in for Dr. Thomas today. Before we hear from our speaker this morning, who'll be introduced by our chiefs, I'd like to introduce you to Deborah Marin, who wears many, many hats in the medical center. I'm sure you all know her, but she's going to talk to us about a new initiative, the Center for Stress, Resilience, and Personal Growth. So Deb, please go ahead and tell us all about it.
Thank you very much. I'm just going to share my screen. There, can you see it? Okay. So I'm just going to present this new center that's opened for about the past actually 6 weeks. It's called the Center for Stress, Resilience, and Personal Growth. And it was developed with the recognition that the healthcare workers for the health system are likely to have developed problems as a consequence of COVID-19. I'm sure you've seen John Rick's work. So it is available for all faculty, staff, and students across the Mount Sinai Health System. So what we offer is the following. We developed an app for Apple, but we're also for Android, that individuals can sign in confidentially and see how they're doing. And based upon how they rate themselves in terms of wellness or psychiatric issues, they will get a score. And yellow means that they may have an issue and they can contact us many different ways, including getting treatment from us. It's also being translated into Spanish and as well. A big part of our program are these resilience workshops, and John Ripp's group is doing a lot of work in this area too. We've developed a manualized resilience promoting workshop series based upon the 10 factors known to contribute to resilience, and we have a range for CME credits to be provided as well. And all employees are also eligible for a confidential mental health screening conducted by our trained staff. Our doors are open basically from 7 a.m. to 9 p.m. 7 days a week, and we're covered by service in the evenings. And we have been getting an increase in phone calls for folks who are seeking advice about how they can get help, including from us. We also are very concerned about community engagement, so we did launch an accelerator, which basically are focus groups to help us hear what the community wants from the health system. So we have employees from across the health system who have met with us now twice, and based upon their feedback, we're translating all the materials into Spanish and are changing some of our workshop series as well for the unions. So as I mentioned, we do have screenings. These are not an Epic. These are a REDCap database that are very secured and on lockdown. And based upon how employees do, we've already actually referred 23 people for care over the past few weeks based upon employees calling us and finding out how they're doing. And this is our team. So in addition, we were initially just going to be a center for referring, but we now are providing free care as well on a time-limited basis to all employees. We're developing that program right now through an FPA practice. This is our team. And please feel free to reach us. You can email me directly anytime if you'd like. I'm deborahmarin.msm.edu. And thank you.
Okay, a very, very important thing to help us through this. Thank you very much, Deb. Okay, so now let's start Grand Rounds, and Dr. Womer is going to introduce our speaker.
We're very excited to have everyone here for this installment of our virtual Grand Rounds series, and we're very fortunate this morning to have speaking for us Dr. John Levine. Dr. Levine completed residency in pediatrics at the Children's Hospital of Los Angeles, followed by a fellowship in pediatric hematology and oncology at Memorial Sloan Kettering Cancer Center. He joined the faculty at the University of Michigan and there directed the pediatric bone marrow transplant program and ran an extensive clinical research program in graft versus host disease, which is the main complication of bone marrow transplants. He moved to Mount Sinai in 2015 and co-founded here the Mount Sinai Acute GVHD International Consortium, or MAGIC, which has since become the world's premier GVHD research organization. He and his collaborators invented a blood test that predicts GVHD outcomes at the onset of symptoms that is now widely used by clinicians everywhere. And today he will discuss some exciting aspects of this research program. Please join me in welcoming Dr. John Levine.
Thank you for the introduction. Let me share my screen. So is that visible?
Yes.
Great. Let's see. Okay, so Today, going to talk about how we're transforming the treatment of graft versus host disease through the Mount Sinai Acute GVHD International Consortium, or henceforth known as MAGIC. Just to reveal the conflict of interest disclosures, I'm a co-inventor on a GVHD biomarker patent that is licensed to Viracor, receive research support from Kamada and Incyte, and consulting honoraria from Novartis and Incyte. So this is a general internal medicine audience, so I thought I would just give a little background around graft versus host disease. So as you know, allogeneic bone marrow transplant is a curative therapy for many hematologic malignancies and blood disorders like sickle cell disease. And it works by replacing the unhealthy marrow with healthy cells. But then there's this other really important piece to, especially relevant for patients with malignancy, which is that the donor T cells that are part of the marrow graft can recognize and kill the recipient leukemia cells. And this is referred to as the graft versus leukemia effect, and is probably one of the principal ways in which allogeneic bone marrow transplant can cure chemotherapy refractory hematologic malignancies. But the principal complication of bone marrow transplant is graft versus host disease. And in this scenario, the donor T cells recognize and attack the healthy recipient tissue as being foreign, and that's graft versus host disease. The terminology of the graft is really bone marrow transplant just kind of lifted that from the solid organ literature, where the solid organ is grafted into the recipient. And then rather than calling it GVRD, we call it the host instead of the recipient. So the major challenge in allogeneic transplant is to prevent and control graft versus host disease without losing that critical graft versus leukemia effect. So there's always been an attempt to strike a balance between the complication and the cure. So moving into just the conception of graft versus host disease pathophysiology, it's actually all the way up until the end of the 1980s, everything about graft versus host disease was thought to be just about the T cells. But since then, we've uncovered a number of other key mechanisms that have shifted the paradigm. So this figure is a modified figure from a conceptual framework that was put forward by Joe Anton and Jamie Farrar in 1992. And the idea is that we start at the top, which is the recipient conditioning tissue damage. So before a patient receives an allogeneic transplant, they first undergo some form of chemotherapy or radiation therapy to both eliminate as much as can be done, any recipient malignant cells, but in addition to also eliminate the recipient immune system in an attempt to prevent rejection of the donor bone marrow transplant. That conditioning regimen, the chemotherapy and or radiation, induces tissue damage in the patient. It's inevitable. And the body has a response to damage, which is the releases inflammatory proteins or inflammatory cytokines. And those cytokines, and this is all occurring before we've done the transplant. This is prior to the infusion of the donor cells. And what those inflammatory cytokines do is they activate host antigen presenting cells. The picture here, that is a dendritic cell with all those sort of octopus-like tendrils that are sticking out, and they're presenting antigen in response to injury. And the idea, of course, is that under the most common scenario is that injury is some sort of breach in the host defense system, the skin or the GI tract or whatever, and there's been infiltration of pathogens, and then those pathogens are supposed to be processed by the antigen presenting cells and then presented to the patient's T cells in order to induce an immune response. But in this case, there hasn't been a breach, an external breach. It's a chemotherapy-induced damage. And although the host antigen presenting cells are now activated and presenting to their presenting antigen, they're presenting host antigen. And the host T cells that are still there, they'll come by and they'll see that and they'll say, no problem, because they recognize self. But the donor T cells, once you infuse them, and so this process actually starts on the day of the transplant, the donor T cells come and see those activated host antigen presenting cells react to the host antigen and then start to proliferate. And after they proliferated into sufficient numbers, the cytotoxic T lymphocytes are prevalent enough that they can start causing damage and cell death to the recipient healthy tissue. So the steps that lead to the graft versus host disease, clinical graft versus host disease, which typically doesn't manifest itself until about 2 weeks after the transplant, are actually initiated both prior to doing the transplant and then as soon as you actually infuse the cells, you start the process. And the delay in the symptoms is largely related to the amount of time it takes for the donor T cells to proliferate. In addition, the patients are receiving medications to suppress donor T cell proliferation. So that sort of sets up a number of scenarios that we can think about how we can identify what's going on before the patients are symptomatic, or to understand more what's happening at the time of symptom development. Oh, and I should have also mentioned on this previous slide one other thing. That damage to the target cells in the tissue also releases proteins related to the contents or the damaged tissue. So there's another, as we move forward to how we develop the blood test, this is also quite relevant, which is, can we detect the damage to the target tissues before or early on in the development of the symptoms. So since I'm assuming that many of you haven't seen graft versus host disease in many years and haven't thought about this, this topic, I thought I'd just sort of briefly review at a very high level GVHD symptoms and their treatment. So there's two forms of graft versus host disease. There's what we call acute GVHD, which typically develops in the first weeks to months after the transplant. And then a later form called chronic GVHD, which develops months to years after the transplant. The two timeframes can overlap, and the manifestations are can be quite different, but the focus here at Mount Sinai is around acute GVHD. So acute GVHD has three classical target organs: the skin, the liver, and the GI tract. And those manifest themselves as either rash, jaundice, or diarrhea. GVHD is graded on a severity scale of 1 to 4, which is based on a composite of the individual target organ stages. And the standard treatment is high-dose steroids, which induce responses in about 50% of the patients. Steroid refractory GVHD, particularly when it involves the GI tract, accounts for the majority of graft versus host disease deaths, which is about in the range of about 20% of patients who undergo an allogeneic transplant will die from GVHD. So it is a big problem. Other than steroids, there's only been one new FDA-approved treatment in the past 50 years, which is ruxolitinib, a JAK inhibitor, for steroid refractory GVHD. We'll talk a little bit more about steroid refractory GVHD later in the talk. So I don't think there's a need to show you pictures of jaundice or diarrhea, but here's a picture of skin GVHD staging. So this is a child that I took care of. This is a stage 1 skin rash. You can see, hopefully on your screens, that there's a reddish rash to his palms. That's a very stereotypical presentation. Very few diseases actually cause rashes of the palms and soles. This is a few days later. He has a much more extensive rash. You can see it's a lot more confluent and extends over the more of the body surface. So a stage 3 rash means that more than half of the body surface is covered. And then this is just a picture of this left foot you can see it's really quite confluent. A stage 4 rash would be desquamation and blistering like a burn. So let's now, I mentioned the severity grading of GVHD, and we know that maximum GVHD severity influences survival. So here you can see from this 2013 paper, this is data from the Fred Hutch, as the maximum severity increases, the non-relapse mortality increases in a very steady, stepwise fashion. The problem with basing your treatment on maximum severity is that it can only be determined in retrospect, because you don't know maximum severity when the patient presents. You only know maximum severity after you've followed the patient's clinical course. So it has a lot of meaning, but the clinical meaning is only can only be determined after the fact. And when we look at the severity of GVHD at onset, when you have to start making treatment decisions, it doesn't actually predict outcomes. So this is data from 300 patients who were prospectively enrolled on and NIH-funded GVHD clinical trials. And you can see that the only criteria was that the patients had to have GVHD that the physician wanted to treat with high-dose steroids and was willing to randomize the patient to an additional therapy. And you can see that there's just no difference in the response to the primary therapy in terms of the complete response or partial response rate at day 28 after the initiation of therapy. So that's identical. This is the response, clinical response at day 28 is the FDA approved validated surrogate for long-term survival. And when we see those same patients just looking at the cumulative incidence of non-relapse mortality, you can also see that there's just no difference in the likelihood of experiencing non-relapse death based on the severity of the GVHD at onset. So that's created a problem where because the severity doesn't guide the treatment particularly well, you have patients who are being both overtreated and undertreated. And that carries on, it creates lots of potential for both complications and treatment failure. So given that dilemma, we started thinking about, well, what are ways in which we could improve upon the outcomes? Could we develop a better test that predicted what would occur? And we're thinking about GVHD biomarkers. So I showed you at the very beginning that GVHD is an immune-mediated inflammatory disease process that results in tissue damage such as diarrhea. And there are lots of things that we can use to detect the activation of the immune system, such as cytokines that activate the immune system, like interleukin-2 or tumor necrosis factor, both of which are released in the early stages of the process that culminates in clinical symptoms and continue to be released during clinical symptoms. And then what about the tissue damage side of the equation? So can we, since GVHD induces tissue damage, can we measure that, the release of proteins related to target organ damage? And one of those proteins is a protein called REG3 alpha. It's an intestinal antimicrobial peptide that is released when the GI tract is damaged by immune processes. It's actually a really interesting protein. So there are a lot of proteins that are released by the Paneth cells in the GI crypt, and they're secreted into that mucus layer that lines the intestinal tract, and they form part of that last line of defense to keep the both commensal and pathogenic bacteria within the GI tract from penetrating across into the bloodstream. And REG3 alpha is actually it's like these little spikes. It's like barbed wire in that mucous membrane, and it just sort of slices, in particular, Enterococcus as it tries to penetrate the mucus layer. It also turns out that it has a lot of other properties, like most proteins, when you study them a lot, they're pleiotropic. So it also provides a survival signal to the intestinal stem cells. So we asked the question, could this, after that protein had been discovered in in graft versus host disease. So we asked this following question. So we looked at a large number of patients who had GI, to see if we could use RAG3 alpha to see if it was a specifically related to GI GVHD. So the first question that we asked was to compare RAG3 alpha concentrations in the serum from 167 patients with GI GVHD that was biopsy proven to 362 patients who didn't have GVHD. And you can see that it's significantly elevated. But as a clinician, I don't need a blood test to tell me that the patient has diarrhea. I know that the patient has diarrhea. So the real question is RAG3 alpha elevated when the patient has diarrhea that's a manifestation of GVHD compared to infectious diarrhea? And you can see that that's absolutely the case. And not only is it higher in the patients with GI GVHD, but the patients who have diarrhea from non-GVHD causes, there's no elevation. It's the same as the control patients. So that's helpful, but that doesn't tell us if it's specific to GVHD, but it's specific to the GI tract. So we also looked at another 290 patients who had just skin GVHD. And again, we can see that it's a significant difference in the serum concentrations. So the take home here was that this RAG3 alpha was the first ever GI GVHD specific biomarker. So we wanted to, that was just one example, and we wanted to now see if we could develop a blood test that would be predictive of GVHD outcomes. So that was good for diagnosis, but then what happens? Now, what I didn't show you is that the concentration of RAG3 alpha at GVHD onset correlated with the likelihood of non-relapse mortality. But it wasn't the RAG3 alpha threshold that was predictive of mortality differed based on the center at which we had samples from the University of Michigan, from the University of Regensburg, and from Kyushu University in Japan. And what we found was that it was kind of a different threshold between each of the three centers. So we knew that we couldn't create a blood test that would be applicable, widely applicable, unless we could create an algorithm that would overcome center effect. So we started this study where we used several validated GVHD biomarkers. Both we started with TNFR1, which is the receptor, one of the receptors for tumor necrosis factor, and the receptor for interleukin 2, which were we had validated as biomarkers, systemic biomarkers for GVHD. Elephant, which is a skin GVHD specific biomarker, RAG3 alpha, which I discussed, and then ST2, which is another, it's the IL-33 receptor. It's relatively specific for the GI tract, and it had been shown to be predictive of resistance to steroid treatments. And since no single biomarker predicts outcome across different transplant practices or patient characteristics, we had the hypothesis that a panel of biomarker concentrations at GVHD onset could overcome center effect and stratify patients for risk of non-relapse mortality at 6 months from the onset of GVHD. And we chose non-relapse mortality as the endpoint because it's clearly objective. The patients died and they haven't relapsed prior to death. So we thought that this would be the strongest objective signal, with a planned intent to take it back to see then if this worked, to then see if it also predicted response to treatment. So when we started this study, we wanted to have a training set to develop the algorithm, and we used 328 patients from 2 centers, the University of Michigan and the University of Regensburg, who had GVHD of any severity, and who also had a research sample obtained within 72 hours of onset. And we tested every combination of the 5 biomarkers, and we used a statistical method called competing risk regression to determine the best model, which was a combination of 3 biomarkers, ST2, TNFR1, and RAG3. And what the algorithm generates, this competing risk algorithm generates, is a probability of 6-month non-relapse mortality for each individual patient, and it ranging from 0.001, which would mean almost certainly going to live, to 0.999, which means almost certain death. And we took that continuous output and we identified thresholds for low, intermediate, or high risk that we selected in advance. We wanted a threshold that gave less than 10% non-relapse mortality for low, and a threshold for high that would be greater than 40% non-relapse mortality, and intermediate was allowed to float in between, but it conveniently ended up halfway in between at 25%. And we did this work at Michigan, so we called these Ann Arbor scores, and the corresponding scores for low, intermediate, and high are 1, 2, and 3. And then we wanted to validate the algorithm, so we used an independent test set of 164 patients that weren't used to develop the algorithm from the same 2 centers, and then a multi-center validation set, which were those 300 patients who were treated on multi-center trials, but no patients from either Michigan or Regensburg. So here's the results from that study. So the first thing I'm going to show you is in this panel on the left is the training set data. So this is where everything's optimized. If it doesn't work here, it's not going to work anywhere. On the y-axis is the non-relapse mortality, and then the x-axis is months from the onset of GVHD. And our endpoint is at 6 months for non-relapse mortality, but the curves go out to 12 months to let you see kind of the whole picture. So here's Ann Arbor 1 in black with 10% non-relapse mortality. Ann Arbor 2 in blue, it's at 25%, and Ann Arbor 3 ended up at about 43%. And it's clear significant differences, unlike originally where I showed you that the onset severity doesn't predict non-relapse mortality. The Ann Arbor scores clearly do, when designed. So we were very happy when using patients from those same 2 centers, we were able to reproduce the same results. But then the key was that when we applied this to multi-center data, the data again reproduced with really quite remarkably similar curves. So we were pretty excited about these results because we felt that this meant that we had overcome center effect. And importantly, we saw that the Ann Arbor scores do not correlate with relapse. So they're really telling us about the non-relapse mortality, and they're not predicting the risk for relapse. So as a result, that translates into all the differences that we see in terms of non-relapse mortality translate into differences in overall survival. So then we took the additional step, which is we went back and said, let's tie this to treatment response, because we want to make sure that the reason this is working is because it's predicting the reason it's predicting non-relapse mortality is because it's telling us who's going to respond to treatment. So we're looking again at day 28 after the start of steroids, which is the surrogate for long-term survival, and this is complete response is on the y-axis. And you can see that in the training set, there are significant differences with decreasing likelihood of responding to steroids as the Ann Arbor score goes up, and that reproduces for almost all of the comparisons in the test and the independent validation set. So at this point, we felt we now had a workable algorithm that we could start using in clinical trials to guide treatment. But we then encountered a complication, which was that the manufacturer changed the SD2 assay. So we needed to rederive the algorithm. And this was all work done here at Mount Sinai. And when we rederived the algorithm using the same biomarkers as before, but we now had using the MAGIC Consortium samples from MAGIC Consortium patients, so we had a much larger cohort of 1,287 patients. We were able to reproduce, we were able to create a new algorithm that worked as well as the the old algorithm, but with a more sensitive and accurate SD2 assay, turned out that we didn't need to keep TNFR1 in the equation. So the magic algorithm is just the combination of two biomarkers, SD2 and RAG3 alpha. So why does this work? How do we like go into the black box and see what's happening? Well, this is what we think is happening. This is a very angry T cell having destroyed a PANOPH cell as part of the graft-versus-host disease reaction. And PANOPH cells sit next to the intestinal stem cells, which are necessary for regenerating the GI crypt. And here, that cell is missing. Here's an intestinal stem cell it's undergoing apoptosis and it's dying. The mucus layer has been broken. There's a breach in the system, and both RAG3 alpha, which are the blue dots, and ST2, which is shown here, coming both from the intestinal epithelium and the intestinal endothelium, is being released into the bloodstream. So we think of the algorithm now as a liquid biopsy of the GI crypt, and that when the height of that probability score directly correlates with the extent of GI crypt damage. And the more damage, the less likely it's going to be able to repair, and the more likely the patient's going to die. So having now walked you all the way through to the development of the test, I'd like to spend the rest of the talk talking about how we're now actually using it, so in clinical applications. So the question is, can we use biomarkers to guide GVHD treatment? That is, can we select the treatment based on the patient's risk for treatment failure, like we do for other diseases? So the idea of using blood tests to guide treatment is not novel. We use HIV PCR to guide antiretroviral therapy, or another test that we do is we use minimal residual disease to guide leukemia treatment. So we're not basing the treatment on the patient's clinical symptoms, but we're basing the treatment based on these objective laboratory measures. And what we're trying to do here at Mount Sinai is move the field away from looking at how angry and extensive a rash is, or how much diarrhea the patient says that they have, towards using the blood test to guide the treatment. And in order to do that, we created the Mount Sinai Acute GVHD International Consortium. This is founded by Jamie Farrar and myself. And we have a large number of centers that are representative of different BMT practices. So one of our goals is that MAGIC be reflective of what's actually contemporaneously happening out in the world. So I won't go through this long list. You can kind of glance at it, but you can see it's both a large number of centers here in North America and in Europe, primarily in Germany, where our key collaborator is Ernst Haller at the University of Regensburg, and then we have collaborators in Bangkok, and about 15% of the patients come from children's hospitals, but 85% of the patients are adult, as you would imagine. So in MAGIC, we have multiple number of studies. Our largest study is a natural history study that enrolls 700 allogeneic recipients annually across all of the different centers. And those patients are followed from the day of the transplant for 2 years, where we get weekly GVHD staging on them, and we also get where we get weekly GVHD staging for the first 100 days, and then for any GVHD that develops prior to 6 months. So we have a really rich GVHD database. One of the keys to the success of MAGIC is that the MAGIC centers have harmonized their practices around graft-versus-host disease. So everybody, a patient seen at the University of Hamburg who has a skin rash and diarrhea will be staged identically to a patient at Ohio State University. And it was necessary to create that harmonization around the practices, because although the staging system has been around since the 1970s, it never came with a guidance manual about how do you determine what should count to the rash? How do you deal with patches of rash? What are the criteria for quantifying the diarrhea when the patient, when you haven't had it actually quantified through measuring the stool volumes, which of course is often played with inaccuracies. So we came up with a set of rules that have now been endorsed by NIH and the FDA and the European Bone Marrow Transplant Group. So the magic system is become now the standard for staging GVHD around the world. But we've gone further in that we teach the system to all of the centers who are doing the staging so that everybody does it in the same way. And then since our goal is to incorporate biomarkers into the clinical care of patients, we obtain research samples, and they're obtained both on a calendar schedule, like 7 and 14 days after the transplant, as well as at GVHD onset and during treatment. We have 5 clinical trials, 3 in the US and 2 in Germany. They're all phase 2 trials. And I'm just going to focus on 2 of the 5 trials to give you a flavor of what we're up to. So the first is our trial I want to discuss is our high-risk GVHD trial. So as I mentioned back at the beginning, the non-relapse mortality is driven mostly due to steroid-refractory GI GVHD. And the symptoms at GVHD onset are poor predictors who will develop steroid-refractory GI GVHD. But we know that the patients with Ann Arbor 2 or 3 GVHD, that is, those with high biomarkers, are more likely to develop steroid-refractory GI GVHD. So our hypothesis was that if you giving more intensive treatment before steroid-refractory GVHD develops will improve outcomes. So we wanted to initiate treatment once we got the scored the patient by their biomarker test. So in order to do that, you needed to have a treatment that you think would be effective. So if it's not just identifying the patients, but then you need an intervention. So we were aware of this work from Mass General that showed that the alpha-4 beta-7 integrin is increased in acute GI GVHD. So this is the percent of memory T cells expressing alpha-4 beta-7, and on the left are samples from patients with GI GVHD, and on the right are samples from patients with skin or no GI GVHD, or no GVHD at all. And what you can see is that there's more alpha-4 beta-7 integrin expressed, more alpha-4 beta-7 positive T cells in the patients with GI GVHD. And why is that so? Well, the answer is that alpha-4 beta-7 integrin is used to facilitate the T cell adhesion to the endothelium prior to trafficking into the tissue. And there's a FDA-approved drug called NATALIZUMAB. It's a monoclonal antibody that blocks T cell trafficking to the GI tract. And what it does is NATALIZUMAB binds to the alpha-4 component of the alpha-4 beta-7 integrin and prevents the integrin from interacting with its corresponding protein on the endothelium, preventing it from adhering, and it just those T cells that want to traffic to the GI tract are just stuck in endless circling of the airport. It was approved by, NATALIZUMAB was approved by the FDA for Crohn's disease in 2008. It also blocks alpha-4 when it's part of the alpha-4 beta-1 integrin, which is how T cells traffic to the central nervous system. It's actually much more widely used for multiple sclerosis, but it was shown to be efficacious in inflammatory bowel disease. So we are running a clinical trial where we identify patients who have high-risk biomarkers at the onset of symptoms, and then they are treated with steroids, and then we're adding in NATALIZUMAB to try to improve outcomes. It's a multi-center trial being conducted at 12 centers here in the United States, and we've accrued 71 out of a planned 84 patients. We expect to finish accrual by COVID, of course, knocked the schedule off, but we expect to finish accrual by early 2021 and then have the results sometime next year. So the goal of that trial is to improve upon, seeing if we can improve upon outcomes when patients are identified as high risk and before the steroid treatment fails, start more intensive therapy. But what about the patients who have low risk GVHD? So they're those patients who respond to high dose steroids. They have excellent survival, but they get a lot of steroid exposure. So the typical treatment course is weeks to months of systemic steroid therapy. And steroid-related morbidity continues to be a major problem. And we looked at the patients enrolled in MAGIC, and we saw that in patients who have low-risk disease, they still, more than half of them will develop a serious infection within 90 days of the initiation of steroid therapy. So that's just one of the measures of morbidity. So we had a hypothesis that patients with low risk or Ann Arbor 1 GVHD could be treated with minimal steroids or even no steroids because they have such a high response rate to steroids and they have such low non-relapse mortality. And in addition, we've thought that if we can minimize or eliminate steroids, we would see fewer infections compared to controls. So again, we need a drug to test, to substitute for steroids. And we went to that, started with that FDA approval for ruxolitinib, so which is a JAK inhibitor. So there was these REACH trials that were phase 2 and actually phase 3 trials that tested steroids plus or minus ruxolitinib for steroid refractory GVHD. And the day 28 response rate with ruxolitinib was 55%. The patients responded within 10 days. And the main toxicities were hematologic. The reason, well, I'll get to that in a second, and it's an FDA-approved drug. It inhibits both JAK1 and JAK2. And in addition to its proven clinical efficacy in patients, both experimental and human studies of both acute and chronic graft versus host disease led to the understanding that the GVHD benefit from JAK inhibition comes through blocking JAK1, but that the side effect, the myelosuppressive side effects, are actually due to JAK2, because JAK1 pathway mediates the production of inflammatory cytokines, and the JAK2 pathway mediates the production of hematopoietic growth factors. So there's another JAK inhibitor that's not yet FDA approved called ITACITINIB, and it's an oral selective JAK1 inhibitor, and it has fewer hematologic side effects than ruxolitinib. And in a quite small study of patients with primary receiving itacitinib plus steroids as initial therapy for GVHD, the overall response rate was quite high, and there also was an efficacy signal in steroid refractory GVHD. So that led us to hypothesize that we could potentially replace steroids with this JAK1 inhibitor. So we're conducting a phase 2 multi-center trial of itacitinib as a daily treatment in lieu of steroids for patients with low-risk GVHD who are identified as having Ann Arbor. At the time of the onset of GVHD, their blood test shows that they have Ann Arbor 1 disease. So we're giving them a 28-day induction with daily itacitinib, and the primary endpoint of the trial is the overall response rate at day 28, which, as I mentioned, is the surrogate for long-term survival and what the FDA is looking for. But we weren't sure how long the patients should be treated for. Actually, in the ruxolitinib trials, they get ruxolitinib for 6 months, but That's for steroid refractory GVHD. And we thought that, we hoped that 2 months would prove adequate. So we're giving the patients, if they respond, another 28-day cycle. And then the secondary endpoints includes the serious infections. And what we hope to show is not only is itacitinib an effective treatment for low-risk GVHD, but there's a quantifiable benefit of not receiving steroids in that the patients have fewer infections. This trial is accruing quite rapidly. We've enrolled 42 out of our planned 70 patients, and we should be able to complete this trial also in early 21. So in the last few minutes, I just want to, those are two of the clinical trials. I want to talk a little bit about some future directions. So what about GVHD treatment response? We've talked a lot about that the endpoint for trials is day 28, but physicians don't wait until the patient's been treated for 28 days to decide whether the treatment is working or not. Those decisions are often made much earlier. And often really a kind of the most common time is after 1 week of treatment. It's a typical decision-making time point where patients who are responding to steroids and start their tapers, and patients who have not responded are often start another line of therapy. And we had the hypothesis that biomarkers at 1 week of treatment could guide those decisions. So in this study, we studied 507 patients with GVHD treated with systemic steroids, and we divided them into 3 cohorts, a training cohort and 2 validation cohorts. The first validation cohort were 142 patients using samples that had been previously collected over a 10-year period. And then the strength of the MAGIC Consortium was the second cohort, which was second validation cohort, nearly as large, were just patients who got treated in 2016. And we evaluated their clinical outcomes, including treatment response after 1 week and their biomarker score. And then we classified the patients as high or low by the MAGIC algorithm. So let's look at those patients who are steroid refractory. These are from the training cohort. We have 122 patients who did not respond after 1 week of treatment. Their GVHD had not improved, and they have 42% non-relapse mortality. And when we actually separate them into high and low by biomarkers, and it turned out that in the training cohort, it just turns out that that threshold was the median. We can see that the large differences in the survival, so that patients who have not responded to treatment but have low biomarkers have much less non-relapse mortality than patients who are steroid resistant and have high biomarkers. And the threshold was derived using a machine learning algorithm. So what about, so that was the initial attempt to determine the threshold, and now we applied that threshold to the 2 validation cohorts. So again, we have now 80 patients from that first validation cohort who had not responded to steroids. You can see again that their non-relapse mortality, it looks very similar to the patients in the training cohort. And now we see again, a large number of those patients have low biomarkers, so they likely don't need additional therapy, and their non-relapse mortality is quite low. And when we apply that just to the patients from 2016, we see an even higher proportion of the patients have low biomarkers. And again, we're seeing quite low non-relapse mortality. So that led us to conclude that when physicians are making the treatment decisions because they've given the patient a week to respond, many of those patients actually do quite well, and they might just simply be slow responders, and you could wait. But the patients with the high biomarkers, there's no time to waste. They need additional therapy. So, and that's one of our goals is we're now going to do a high-risk trial for patients with steroid refractory GVHD and high biomarkers as part of our NCI program project grant renewal application. Then the last thing I want to go over is the idea of the biomarkers as a response measure. So we've talked again a lot about this day 28 clinical response, that is the accepted endpoint for treatment trials. And it does correlate with long-term survival, but it's not, the sensitivity and specificity are not great. But there's been no response biomarkers for GVHD that, yet had not yet been validated. And the FDA NIH definition of response biomarker is something that measures a biological response, i.e. a change from baseline, which could be as simple as I think the urine protein creatinine ratio is an FDA validated response biomarker. There's actually not a lot that have been achieved the FDA stamp of approval. Our hypothesis was that the MAGIC biomarkers would more accurately gauge response than clinical symptoms after 4 weeks of treatment. So this would be, we have the clinical measure of disease activity, and now we want to use the laboratory measure of disease activity. So I'm going to skip this slide just in the interest of time and go to the punchline. So this is the clinical. This is how well the clinical response correlates with non-relapse mortality. And here you can see this is the area under the curve, or the area under the receiver operating curve on the left. So it's if you haven't thought about AUCs in a while, it's essentially a number that's a composite reflection of both the sensitivity and the specificity of a test. After 1 week of treatment, the response to treatment is poor, a poor predictor of ultimate outcome. An AUC of 0.5 means you're doing no better than a coin toss. The test is not more accurate than a 50-50 outcome. So you have to do better than that. But what you do see, and this makes perfect sense, is that the clinical response gets better and better over time at correlating with the outcome. So if the patient, maybe a patient that hasn't responded to 1 week of treatment may not be particularly predictive of whether they're going to live or die. But by 4 weeks of treatment, it's improved considerably. And this is a significant increase. And it's about, at 4 weeks, it's about 0.69 is the AUC. But here are the biomarkers. So there's a couple of lessons here. So the first is, at every time point, the MAGIC algorithm is providing a much more accurate result than the clinical response at the same time point. And when you actually look at the biomarkers after 1 week, it's actually better than the clinical response at 4 weeks. So our take home from this was that this sort of liquid biopsy of the amount of GI crypt damage it's really informative in that after 1 week of treatment, it's telling us if you're seeing healing take place, that's actually apparent, even if the symptoms haven't improved. We wouldn't actually propose that this be a substitute, but we're looking to doing additional studies that then bring the MAGIC biomarkers in as a validated endpoint for clinical trials. And we think that over the next few years, by studying this in our clinical trials, we'll be able to hopefully make a firm case for a laboratory endpoint for clinical trials, just like we do with other diseases. Like many diseases now, we don't just look at the symptoms, but we use laboratory measures to determine whether the treatment's effective or not. So in conclusion, the MAGIC algorithm stratifies GVHD patients into 2 groups with distinct risks for treatment failure, 6-month non-relapse mortality, and overall survival. And we have a number of ways in which we're using this in clinical trial applications. We're doing intensified treatment for high-risk patients. I described the high-risk trial in the US. There's also one in Germany using a different treatment. De-escalating treatment for low-risk patients. I described the US one, and then there's another one taking a slightly different approach in Germany. And then our plan is to guide treatment decisions for early non-responders and hopefully avoid the unnecessary escalation of treatment in patients who simply just need a little bit more time. And a novel response biomarker for clinical trials. So I need to, of course, acknowledge this is a massive amount of team science. Chief collaborator is Jamie Ferrara, who has the lab. I oversee the clinical side of MAGIC, and he oversees the laboratory side of MAGIC. And our statistician is Umet Ozbek. And then there are a lot of additional people working on this here at Mount Sinai, in Regensburg, at the MAGIC centers across the world. And then just want to recognize our funding sources that are listed here. So thank you. We have a few minutes, I guess, for questions.
Okay, thank you very much. It's very exciting and very interesting. There are already a couple of questions in the chat section. So Dr.
Let me see if I can open that.
Pick those up.
Yeah, if I can, let me see if I can figure out how to do it. Okay.
And
oh, I see it.
I invite anybody who wants to unmute after we finish the chat questions to ask your question.
Okay. So one of the questions is, can GVHD be treated by antibodies? And the so we're doing the study using our high-risk trial is the monoclonal antibody against the integrin on T cells to prevent trafficking to the GI tract. And then there are a number of other antibodies that are that have potential use in graft versus host disease that would target different aspects of the pathophysiology, either targeting the T cells, different populations of T cells, as well as there are some monoclonal antibodies that actually target inflammatory cytokines like etanercept. And then there's another question, which is, are physicians using the biomarkers outside of clinical trials? And if so, when and how often should they be measured? And as I mentioned at the very beginning in the disclosures, is that ViraCore offers this test, and we're aware that by our calculations, probably about 20% of the patients who are developing GVHD are receiving are having the test ordered to help guide however the local physicians are using it in terms of their treatment decision making. And it's useful at a number of time points, but I think that the primary ways it's being used is both at the onset of treatment to help decide what the initial treatment should be, and during treatment as a measure of treatment response, particularly in patients whose symptoms may not have, the physician wants some confirmation that the symptoms are, the symptom improvement or lack of improvement is correlating with the patient's, what should become the patient's outcome. And we see that sometimes we get some phone calls and we hear from people that, you know, they will, when the biomarkers conflict with the symptoms, they're more likely to agree to follow what the biomarkers are indicating than the clinical symptoms. Any other questions? Oh, could the biomarkers be used for intestinal problems other than GVHD? There is some work here at Mount Sinai actually looking at Reg3 alpha as a Crohn's disease biomarker, and I think that that's playing out, and it might be helpful in the management of inflammatory bowel disease.
Does anybody want to unmute to ask a question? Okay, well, I think I don't see any other questions. So I'd really like to thank our Grand Round speaker for a terrific talk today, and very exciting work that's being done, very important. So I don't know if we can clap.
I'll assume there's widespread applause.
Right.
all muted. We all got enough applause at 7 p.m. every night anyway. So thank you very much. Thank you for the opportunity.
Thank you everybody for coming to Grand Rounds. Have a great day and a good week.